This reading is on Chapter 2, Doctors and Patients, a Framework of Standards for Surrogate Decision-Making, by Tom Beauchamp and James Childress, from Principles of Biomedical Ethics, 6th edition, Oxford University Press, read by Rigo Martinez. A Framework of Standards for Surrogate Decision-Making. We shift now from the conditions of consent to problems of consent when surrogate decision makers are involved. Surrogate decision makers are authorized to reach decisions for doubtably autonomous and non-autonomous patients. If a patient is not competent to choose or to refuse treatment, a hospital, a physician, or a family member may justifiably exercise a decision-making role or go before a court to other authority to resolve the issues before implementing a decision. Since the Quinlan decision in New Jersey in 1976, courts and legislatures in the United States have established many procedures and standards for surrogate decision making. However, much remains unresolved. Many surrogates daily make decisions to terminate or continue treatment for incompetent patients. For example, those suffering from stroke, Alzheimer's disease, Parkinson's disease, chronic depression affecting cognitive function, senility, and psychosis. In this section, we consider three general standards that surrogate decision makers might use. Substituted judgment, which is sometimes presented as an autonomy-based standard, pure autonomy, and the patient's best interest. Our objective is to restructure and to integrate this set of standards of surrogate decision-making into a coherent framework. Although we evaluate these standards for law and policy, our underlying argument is a moral argument that extends our earlier discussions of the value of protecting autonomy. The substituted judgment standard. The standard of substituted judgment is constructed on the premise that decisions about treatment properly belong to the incompetent or non-autonomous patient by virtue of his or her rights of autonomy and privacy. In this conception, the patient has the right to decide and the right to have his or her values and preferences taken seriously, but is incompetent to exercise these rights, and it would be unfair to deprive such an incompetent patient of decision-making rights merely because he or she is no longer autonomous. This standard is a weak standard of autonomy. It requires the surrogate decision maker to don the mental mantle of the incompetent. As a classic court case put it, that is, to make the decision the incompetent person would have made if competent. In this case, the court invoked the standard of substituted judgment to decide that Joseph Sakowicz, a newer competent patient, would not have chosen treatment had he been competent. Asserting that what the majority of reasonable people would choose could differ from what a particular incompetent person would choose, the court said that the decision in many cases such as this should be that which would be made by the incompetent person. If that person were competent, but taking into account the present and future incompetency of the individual as one of the factors which would necessarily enter into the decision-making process of the competent person. The basic premise of the substituted judgment standard here rests on a fiction. An incompetent person cannot literally have the right to make medical decisions when other competent persons in fact exercise that right. The standard of substituted judgment should be used for one's competent patients only if reason exists to believe that the surrogate decision maker can make a judgment as the patient would have made it. In such cases, the surrogate would have such a deep and relevant familiarity with the patient that the particular judgment made reflects the patient's views and values. Merely knowing something in general about the patient's personal values is not adequate. Accordingly, if the surrogate can reliably answer the question, what would the patient want in this circumstance? Substituted judgment is an appropriate standard that approximates first person consent. But if the surrogate can only answer the question, what do you want from the patient? Then this standard is inappropriate because all connection to the patient's formally autonomy has vanished. Similarly, we should reject the standard of substituted judgment for for never competent patients, for newer competent patients. Similarly, we should reject the standard of substituted judgment for newer competent patients. No basis exists for a judgment of autonomous choice if a person has never been autonomous. The standard of substituted judgment helps us understand what we should do for once competent patients whose relevant prior preferences can be discerned. But so interpreted, it collapses into a pure autonomy standard that respects previous autonomous choices. The pure autonomy standard. The second standard, therefore, eliminates the dubious autonomy reflected in substituted judgment and replaces it with a correct account of the role of autonomy. The pure autonomy standard applies exclusively to formerly autonomous, now incompetent patients who expressed a relevant autonomous treatment preference. The principle of respect for autonomy compels us to respect such preferences, even if the person can no longer express the preference for himself or herself. This standard asserts that whether or not a formal advance directive exists, caretakers should accept prior autonomous judgments. This form of autonomy is sometimes referred to as precedent autonomy. It has been invoked for a wide range of circumstances. The classic Clare Conroy case, in which the New Jersey Supreme Court grappled with several standards of surrogate decision making, sheds light on some of the moral issues surrounding the standard. Conroy, an 83-year-old nursing home resident, suffered from irreversible physical and mental impairments, including organic brain syndrome, arteriosclerotic heart disease, hypertension, diabetes, necrotic ulcers on her left foot, and a gangrenous left leg. She was awake enough to track persons with her eyes, but was severely demented, lay in a fetal position, and was unable to speak. She had no discernible cognitive and volitional functioning. Conroy's nephew, Thomas Whitmore, who was her guardian and only surviving blood relative, sought court permission to remove his aunt's nasogastric tube, an action that would result in her dehydration and death in about a week. He appealed to two of her expressed values and preferences: her general fear of doctors and her refusal to have her gangrenous leg amputated. He argued that his request for tube removal would conform to her wishes. Conroy's physician opposed Whitmore's petition as a violation of medical ethics. The trial court authorized removal of Conroy's feeding tube, even though she might die painfully, but a court-appointed guardian ad litem appealed the court's order. The New Jersey Supreme Court ultimately held that physicians could withhold or withdraw any medical treatment, including artificial nutrition and hydration, from an incompetent patient under certain conditions. More specifically, it held that physicians can legitimately withhold or withdraw life-sustaining treatment from an incompetent patient when a subject test, meaning that there is a demonstrable basis in the patient's former autonomous choices, shows that this particular patient, when autonomous, would have preferred withdrawal. The court reasoned that a written document, such as a living will, an oral directive to family member, friend, or healthcare provider, a durable power of attorney, the patient's convictions about medical treatment administered to others, religious beliefs and tenets, or the patient's consistent pattern of conduct with respect to prior decisions about medical care, can, in principle, satisfy the autonomy-based standard. The court further noted that, in the absence of adequate proof of the patient's wishes, it is naive to pretend that the right of self-determination serves as the basis for substituted decision-making. Although we too commend a pure autonomy standard, problems are evident in Conray and similar legal decisions regarding satisfactory evidence for action under this standard. In the absence of explicit instructions, a surrogate decision maker, for example, selectively choose from the patient's life history those values that accord with the surrogate's own values, and then use only those selected values in reaching decisions. The surrogate might also base his or her findings on values on the patient that are only distant relevant to the immediate decision. One can reasonably ask what a decision maker could legitimately infer from Conroy's prior conduct, especially her fear and avoidance of doctors and her earlier refusal to consent to amputation of a gangrenous leg. A recurrent problem is that surrogates that often assume an explicitness in a patient's directive about the future that does not directly show an autonomous preference with regard to the decision at hand. The best interest standard. Sometimes the patient's relevant preferences cannot be known. Under the best interest standard, a surrogate decision maker must determine the highest net benefit among the available options, assigning different weights to interest the patient has in each option and discounting or subtracting inherent risk or cost. The term best is used because the surrogate's obligation is to maximize benefit through a comparative assessment that locates the highest net benefit. The best interest standard protects an incompetent person's well-being by requiring surrogates to assess the risks and benefits of various treatments and alternatives to treatment. It is therefore inescapably a quality of life criterion. Those applying the best interest standard should consider the formally autonomous patient's preferences, values, and perspectives only as far as they affect interpretations of quality of life, direct benefit, and the like. We believe that the best interest standard can, in some circumstances, validly override advance directives executed by now incompetent but once autonomous patients, as well as refusals by minors and by other incompetent patients. This overriding can occur, for example, in a case in which a person has designated another by a durable power of attorney to make medical decisions on his or her behalf. If the designated surrogate makes a decision that threatens the patient's best interest, the decision should be overridden unless there is a clearly worded second document executed by the patient that specifically supports the surrogate's decision. Problems of a person's ability to anticipate a future state often challenge reliance on advance directives. Much discussed are cases of apparently contented, non-suffering, incompetent patients who can be expected to survive if treated against their advance directive, but who otherwise would die. Several discussions have focused on Margot, a patient with Alzheimer's who, according to the medical student who visited her regularly, is one of the happiest people I have ever known. Some discussants of her situation ask us to imagine what would be done if Margot had a living will, executed just at the onset of her Alzheimer's, stating that she did not want life-sustaining treatment if she developed another life-threatening illness. In that circumstance, caregivers would have to determine whether to honor her advance directive and thereby to respect her precedent autonomy by not using antibiotics to treat her pneumonia, or to act in accord with what may appear to be her current best interests given her overall happiness. The challenge is serious. A person slip into incompetence. Their condition can be very different from, and better than, they had anticipated. If so, it seems unfair to the now happily situated incompetent person to be bound by a prior decision that may have been ill-informed. In Margot's case, not using antibiotics would arguably harm what Ronald Dworkin called, in discussion this case, experimental interest, her contentment with her current life. However, providing antibiotics would violate her living will, which articulates her critical interest, her interest in a mode of living and dying that expresses her considered values, her life story and commitments, and the like. Dworkin argues that Margot should not be treated in these circumstances. By contrast, the President's Council on Bioethics concludes that Margot's apparent happiness would seem to make the argument for overriding the living will morally compelling in this particular case. Except in rare cases, we are obligated to respect the previously expressed autonomous wishes of the now non-autonomous person precisely because of the force of the principle of respect for the autonomy of the person who made the decision. Finally, best interest judgments are meant to focus attention entirely on the value of the life for the person who must live it, not on the value the person's life has for others. Quality of life judgments also concern only the individual's best interest, not his or her worth to enhance another's quality of life. Unfortunately, the best interest standard has sometimes been interpreted in highly malleable ways, thereby permitting consideration of values irrelevant to the individual's benefits or burdens. For example, when parents have sought court permission for a kidney transplant from an incompetent minor child to a sibling, parental judgments about the donor's best interests have on occasion taken into account projected psychological trauma from the death of the sibling and the psychological benefits of the unselfish act of donation. Such considerations should be greeted with skepticism and call attention to the need for additional procedural protections such as committee review. In summary, it has been popular, although by no means universal, in biomedical ethics to hold that an ordered set of standards for surrogate decision-making runs from 1. Autonomously executed advance directives, to 2. Substituted judgment, to 3. Best interest, with the first having priority over the second, and the first and second having priority over the third in circumstance of conflict. We have argued that previously competent patients who autonomously express their preference in an oral or written advance directive should be treated under the pure autonomy standard, and we have suggested an economy of standards, that is, we have determined that the first and second positions are essentially identical. The principle of respect for autonomy provides the only foundation, and it applies if and only if either a prior autonomous judgment itself constitutes an authorization or such a judgment supports a reasonable basis of inference for a surrogate. If the previously competent person left no reliable traces of his or her preferences, surrogate decision makers should adhere only to the best interest standard. End of Chapter 2, Doctors and Patients, A Framework of Standards for Surrogate Decision Making, by Tom Beauchamp and James Childress, from Principles of Biomedical Ethics, 6th edition, Oxford University Press. Read by Rigo Martinez.